Hello, this is Chris Ferrigno. In this video, we will be discussing the ankle joint as well as the foot. This is the third of a three-part series on the joints of the lower extremity. Let's first look at the foot, and then we'll take a look at the ankle. There are a total of 26 bones in the human foot. Approximately, there are 7 tarsal bones, 5 metatarsal bones, 5 proximal phalanges, 4 middle phalanges, since the great toe is made up of 2 bones only, and 5 distal phalanges. The tarsal bones include the talus, which is the bone that directly interfaces with the leg. We'll have more on that in subsequent slides. Underneath and posterior to the talus is the very large calcaneus, which is also the heel bone. Anterior to the talus and calcaneus are the navicular and cuboid bones. The interaction between the talus and navicular combined with the calcaneus and the cuboid, this interaction here and here, is called the mid-tarsal joint. Often this is also known as by its eponym, the Chopart joint. Anterior to the navicular bone are 3 cuneiform bones, the medial, intermediate, and lateral cuneiforms. Sometimes these bones are referred to the first, second, and third cuneiforms. For this course, though, please know them as the medial, intermediate, and lateral. The joints between the distal tarsal bones and the proximal metatarsal bones, seen here, is known as the tarso-metatarsal joint, or more commonly referred to as the Lisfranc joint. In these two views, we can appreciate the medial and lateral sides of the foot. Medially, we can see the large medial facade of the calcaneus with its large prominences, its tuberosity, and the sustentaculum tali. The tuberosity serves as primary weight-bearing surface, while we'll see later that the sustentaculum tali serves as an attachment point for a spring ligament, also serving as a pulley for a muscle. More anteriorly, we can see the medial aspect of the talar head, the navicular, and the first or medial cuneiform. Anterior to that, we can see the first metatarsal, the first proximal phalanx, and the first distal phalanx. Laterally, we see the large lateral facade of the calcaneus, the cuboid, the fifth metatarsal with its prominent base and prominent tuberosity, and the fifth proximal phalanx, intermediate phalanx, and distal phalanx. While we're discussing the bony structure of the foot, we should mention concepts called the medial and longitudinal arches. So the medial longitudinal arch is essentially this area on the medial side of the foot. Here we can see in a sagittal plane the arch of the foot on the inside, composed mostly of the calcaneus, the navicular as the keystone of the arch. We have the medial cuneiform, and then the first metatarsal. And we have, as humans, we have varying degrees of arch height. But what does this arch do for us? Well, it helps to distribute weight between the heel and the ball of the foot, or from the calcaneus to the head of the first metatarsal. It acts as shock absorbers during locomotion and allows the foot to accommodate uneven ground surfaces. In other words, this part of your foot is allowed to move this way, while this part of the foot is allowed to move that way. The arch is supported by several passive and active structures. The active structures shown in blue include the tibialis anterior, which is pulling up here on the first cuneiform and the base of the first metatarsal. So it's pulling up that way. Here we have the tibialis posterior shown in gray, pulling up and back on the navicular bone. We have the flexor hallucis longus pulling back and slightly up on the proximal and distal phalanx. The intrinsic muscles of the foot also help to maintain these arches. Here we see the flexor hallucis brevis muscle extending from the calcaneus to the metatarsal heads. Passively, the medial longitudinal arch is supported by several ligamentous structures. Here we see two of them. The spring ligament, again, goes from the sustentaculum tali to the navicular bone. And then the plantar aponeurosis, which is extending down off of the calcaneus all the way over to the first metatarsal. The lateral longitudinal arch, seen here, is supported primarily by the fibularis longus and brevis on this lateral side, as well as the calcaneo-cuboid ligament. Here we can see this calcaneo-cuboid ligament that's extending from here to here. The ankle is often described as the joint between the talus and the overlying tibia and fibula. Realize, however, that the ankle is a very complex series of interactions between several bones, namely the tibia and the fibula, the talus, and also the calcaneus. While not a synovial joint, the tibia and fibula connect through their course as a syndesmosis, with ligaments and muscles that help to keep them anchored to one another. There is a robust interosseous membrane or ligament that courses along the course of the tibia and fibula. The distal part of this interaction plays a key role in forming the ankle. The talocrural joint is composed of a structural mortise composed by the fibula and tibia. The talus is nested up in this mortise, thus forming the tenon of what is described as a mortise and tenon joint. Because of this configuration, this part of the ankle joint allows for movement mostly in the sagittal plane. At the ankle, sagittal plane motion is described as plantar flexion and dorsiflexion. Realize that the dorsum of the foot is this surface, while the plantar surface of the foot is this surface. Therefore, dorsiflexion is taking the dorsum of the foot up closer to the shin, and plantar flexion is taking the plantar surface of the foot down towards the ground. The subtalar joint refers mostly to the interaction between the talus and the underlying calcaneus. This joint allows for motion in all three planes of motion, but mostly in the frontal plane, which at the ankle is coined inversion and eversion. Here we see inversion, where the sole of the foot points inward, and here we see eversion, where the sole of the foot points outward. The ankle complex relies on a robust network of ligaments to help support the three joints that help to make up this complex. Medially connecting the tibia to the navicular, the talus, and the calcaneus is the deltoid ligaments. There are four named ligaments that you do not need to know. However, you do need to know and appreciate that the deltoid ligament resists ankle eversion. While we're on this slide, I'd like to point out one other ligament that technically is not crossing the ankle joint. This is the spring ligament, or the plantar calcaneonavicular ligament. The spring ligament is very important for providing structural integrity to the foot, particularly for the medial arch. Here you can see that it's connecting the sustentaculum tali of the calcaneus to the navicular bone. And this ligament helps to hold up the arch of the foot. Without this ligament, either because it's been ruptured or more commonly because it's been stretched out, this arch falls, thus reducing the structural integrity of this arch. Laterally, the ankle has 3 primary named ligaments. You should know the names of these ligaments since they are individually sprained. All 3 of them end with the term fibular. From posterior to anterior, they are the posterior talofibular ligament, seen here, the calcaneofibular ligament, seen here, and the anterior talofibular ligament, seen there. This last one, the anterior talofibular ligament, is the most sprained ligament in the body, and therefore all of you will encounter patients during your training or in your practice with an injury to this structure. In addition to the ligaments spanning the talocrural joint, there are anterior and posterior tibiofibular ligaments that connect the distal tibiofibular joint. These are extremely important in keeping the tibia and the fibula in close proximity to one another. They work in conjunction with the anterior interosseous ligament to stabilize the leg bones. A high ankle sprain includes any one of these 3 ligamentous structures. With forceful frontal plane motion, i.e. eversion or inversion, one or both of the malleoli may fracture. For example, the left image is showing a bimalleolar fracture resulting from forceful eversion. The medial malleolus fractures due to the calcaneus moving rapidly away from the medial malleolus. Since the deltoid ligament, seen here, is so robust, the medial malleolus avulses from the tibia. Meanwhile, the calcaneus moves into the lateral malleolus, compressing and ultimately fracturing the lateral malleolus in the process. Again, this was due to uncontrolled eversion. With forceful or uncontrolled inversion shown on the right, the calcaneus is moving away from the lateral malleolus of the fibula. Often the calcaneofibular ligament will rupture, but sometimes it won't, and the distal fibula will instead fracture. Again, this is more of a traction fracture versus this is more of a compression fracture. Pes planus is the medical term for flat feet. As I've alluded to, the foot requires extensive support from many structures. For a variety of reasons ranging from genetic predisposition to soft tissue injury to chronic influence of gravity, pes planus can occur when either active or passive structures fail. Several consequences of pes planus include foot pain, plantar fasciitis, medial ankle pain, particularly in the tarsal tunnel due to tendinitis of the tibialis posterior, and weight bearing on the midfoot skeleton such as the navicular bone. Both this individual and likely this individual are weight bearing on their navicular bone. Of course, changes at the foot have significant consequences higher up in the lower extremity, which reduces gait inefficiency. Limbs are often externally rotated, as we can see in this individual. Normal heel-to-toe gait is difficult or impossible, and the foot loses its capacity to be a rigid lever. Here, this individual would have what we would call a rigid lever during toe-off, but this individual is incapable of developing this rigid lever because of a loss of their medial arch. 2 easy clinical assessments to screen a patient is to visually examine the height of the mid-arch. A standard ballpoint pen should easily fit directly under the navicular bone. Also, a too many toes sign test can be performed. When looking at the heel, from the back of the patient, usually only the fifth toe, and about half of the fourth toe should be seen. In a flat foot deformity, more of the fourth toe can be seen, as well as other toes. Here we can see all 5 toes. This concludes the discussion on the ankle of the foot. Please email me if you have any questions or comments. Thank you for listening.